So, what about the specific examination for patient with male infertility? What we concern about here, we should look for the presence of, in general, the presence of secondary sexual characteristic, like the mustache and the beard and the hair growth in the axilla and hair growth in the groin region, and also looking for the muscular building of the patient and the fat to the muscle proportion and the morphology of the male, because deficiency in the androgen may result in decrease in the secondary sexual characteristic, or may result even in gynecomastia for the male. So we should insist about the presence of the secondary sexual characteristic. Then we switch, or we should do examination of the genitalia. And examination of the genitalia, it should be systematic. First of all, we should examine the penis, and the penis looking for the presence of hypospadias. Actually, hypospadias defined as the opening of the urethra on the ventral surface of the penis, distal or proximal to the tip of the glans penis. So the presence of hypospadias may result in efficient deposit of the semen into the vaginal or cervical vault, and may result in infertility. So when we do examination for the penis, we should look for the presence of hypospadias, and also we should look for the approximate size of the penis, because small size penis may indicate deficiency in the androgen in general. And then we should do examination for the testes. The testicular size can be estimated by a device which called the orchiodometer, and the approximate dimensions of the testes is about 3.5 to 0.5. 3.5 for the length, 2.5 for the height, and width about 2 to 2.5. A normal testis, it should be firm, and it should be within the average size that I mentioned. But the abnormal testis usually small in size and soft in texture. And the presence of a small size testis and soft textures mean that the testis most probably diseased or even failed testis. So when we examine the testis, we should keep in mind the size and the consistency or the texture of the testis. And also we should look for any swelling in the scrotal region, which is maybe due to hydrocele, or even maybe due to hernia. And then we should look for the epididymis, which is situated in the posterior lateral surface of both testes. The epididymis should be examined easily by palpation between two fingers of the thumb and the index finger, for the presence of any mass, for the presence of cyst maybe in the epididymis, which is called the spermatocele, or for the presence of any granulomatous lesion or beaded appearance of the penis. Then we should examine the spermatic cord, as we know that the spermatic cord contain the vas deferens and contain the papilliform plexus of the varicose vein, and also contain arteries of the testis, which is the cremasteric artery and testicular artery, and also artery to the vas deferens, and also contain fat and certain lymph node. What we concern about examination of the spermatic cord, we should look for the following. First, we should look for the presence of varicocele. And what is the definition of varicocele? Varicocele is defined as the dilated papilliform plexus which drain the testes. And the varicocele, we have 3 grades of varicocele. Grade 1 that just palpable during Valsalva maneuver, and grade 2 that's palpable without Valsalva maneuver, and grade 3 that's even visible without any need for examination. The varicocele, I will speak a little bit about varicocele. Varicocele presented in about 20 to 40% of the male infertility, and it's considered one of the most important cause of male subinfertility. The left varicocele more common than the right varicocele. About 40% of the male infertility have left-sided varicocele, and about less than 10% of male infertility has right-sided varicocele, and bilateral varicocele is presented in about 10% of the male infertility. Why it's more common in the left side? Because the spermatic vein on the left side come from the left renal vein, and so the hydrostatic pressure and the length of the spermatic vein is much more than the right spermatic vein. And what is the effect of varicocele on the testes? The varicocele affect the testicular count and the testicular motility, and even may affect the sperm count and sperm motility, and even may affect the sperm morphology. So the effect of varicocele on the testes, it caused decrease in the sperm count, we called it oligospermia, and also caused decrease in sperm motility, we called it astenospermia, and cause even change in the morphology of the sperm, we called it teratospermia. What is the mechanism that the varicocele affect the testicular function? Multiple mechanism, maybe due to pressure effect because of the length of the left spermatic vein, and the high hydrostatic pressure in the left spermatic vein may cause testicular atrophy or even damage to the testes. The other mechanism due to reflex of toxic material that come from the left renal vein downward into the testes also may affect the testicular function. And other theories said that the presence of this vein and dilated vein cause an increasing intratesticular temperature, also may affect the sperm quality and sperm production with morphology. So we have 3 mechanisms that how varicocele affect the scrotal function. Actually, the final management of varicocele is by surgery. We have multiple modalities, maybe open surgery or maybe laparoscopical surgery. Then we have now to return into the examination of the vas deferens. We said that we should looking in spermatocord about varicocele, and then also we should palpate the presence of the vas deferens. The vas deferens will appear as a beaded or thick cord within the spermatic cord. We should look whether it is present or not first. Also, we should look for the presence of any pathology, maybe beaded appearance or maybe granulomatous appearance texture, and this usually due to certain infection, maybe tuberculosis infection, chronic infection. But I have to mention that certain cases, in about 2% of the male infertility, there are absent of the vas deferens and also absent of the epididymis. Why this happen? Maybe due to embryological problem that's happened during an early embryonic period. All of us, we know that the ureter come from the paramesonephric duct, and the paramesonephric duct also give us the secondary sexual canal or secondary sexual gland, which is the epididymis, vas deferens, ejaculatory duct, and seminal vesicle. Sometimes if I have problem in the one of the paramesonephric duct. It may affect later on in the future the presence of the epididymis and varicocele, or even ejaculatory duct and seminal vesicle. Also here the ureter may be affected later on in the future. So when I have absence of vas deferens, or even absence of unilateral absence of the epididymis, I expect there is a problem in the ureter, and vice versa. When I have a patient with single kidney due to absence of the or renal agenesis, maybe in the left or in the right side, I expect there will be a problem or absence of vas deferens, or even absence of the epididymis on the ipsilateral side. So any congenital problem that happened in the ureter may affect the presence, may affect later on in the future the vas deferens and the epididymis in one way or other way. So it's very important during an examination of the epididymis, I should look for the presence of the vas deferens. Also, during an examination of the genitalia, we should look for the presence of hernia. And the hernia, there is two types: those with indirect hernia that pass within the spermatocord or patent processus vaginalis, and those with the direct hernia that come from the posterior abdominal wall, because sometimes the presence of hernia even they affect the function of the testis by causing pressure on the varicose vein and causing secondary varicosity, which affect finally the testis. After completion of taking history from the patient and do a general examination and a specific examination of the genitalia, I should switch into the next step, which is the management of this patient.